Righty, let's get going again so we can keep to time. So everything's just going to be 10 minutes later. So we'll get going at 10 past and then we'll go to lunch at 1 o'clock and finish lunch at 1:30. So yes, thank you for coming back so promptly. Fantastic to see so many people here yet again. So it's my absolute pleasure to be chairing this next session and to be able to introduce Professor Susan Curl. So Sue is a geriatrician practising at Hornsby Ku-ring-gai Hospital and also at Bateman's Bay Hospital. And she holds the Curran Chair in Healthcare of Older People in the Faculty of Medicine at the University of Sydney. And she has many other achievements which are also outlined in the program. So I encourage you to look at the full bio there. And so today she's going to be talking about sarcopenia, nutrition and falls. Welcome, Sue.
Morning everybody, it's fantastic to see so many people here. Sally Castell, I just want to say congratulations, you're amazing. And I remember you from way back, and you're an absolute evangelist for prevention, and you still are, which is great. So this morning I'm going to be talking on sarcopenia. How many of you know what I'm talking about? Okay, oh good. Okay, then you'll be able to answer the first question, which is, what do these numbers mean? So in October 2016, sarcopenia was included in the International Classification of Diseases by the CDC, the Centre for Disease Control in the US. So that's a really big deal. It now actually exists because it has a number. And people in the sarcopenia research field got quite excited about it, I can tell you. But it is interesting because it does, if you like, give some clinical legitimacy to something that quite a few of us have been talking about for a long time. So, have a look at this. Which one do you want to be? And actually, what is it? Someone said to me, it looks like a piece of normal steak and a piece of Wagyu steak. And actually, they're probably right. But what it actually is sarcopenia in the thigh. So this is what we're looking at as we get older. And it really is quite important to think about this because all of us are losing muscle mass as we sit here. So probably we should all be standing and doing squats as we're listening. But anyway, but if you notice, the thighs are the same size, but the amount of muscle is much, much less. And that's the big issue. So what is sarcopenia? If you go back to the Greek, it's lack of flesh. Sarx being flesh, penia being lack of. And it's defined, look, there's sort of different definitions. I'll show you where the issues are, but generally it's age associated and it's a combination of low muscle mass and muscle weakness that together cause functional problems. Or some people just say a progressive and generalised loss of muscle mass and strength. But it's not just muscle mass, clearly it's the function that goes with it. And you make the diagnosis based on a mix of muscle mass, which you can measure by DEXA, if you want to get it exactly right, muscle strength, which we usually measure by hand grip strength, using a dynamometer, or gait speed, or both. You measure muscle mass as what's called lean body mass. So it's what's in your arms and legs minus the bones and the fat. So non-bone lean mass. And as I said, muscle strength is usually dynamometer, but chair rise. So how many times you can rise from a chair in 10 seconds. There's all sorts of ways of looking at that. And then, as I mentioned, gait speed. And then when people look at functional limitations, it can be measured just ADL assessment, and I'll show you some assessment scales, gait speed, SPPB, the short physical performance battery. But there is some disagreement over definition and measurement, and I have to declare a bias. Having worked in the Netherlands with a group looking at sarcopenia there, I have very much a European view as opposed to maybe the more American view. But this, and I'm sorry it's a fairly busy slide, these are the definitions, and it's actually quite interesting. If you look at the different, the gait speeds, look, there's not a huge amount of difference between 1 metre a second and 0.8 of a metre a second. But the difference, if you go to the second one down, which is the European Working Group on sarcopenia, their grip strength, have a look at the grip strength. So for men, it's 40 kilos, so you've got to be able to press 40 kilos if you're a man, and 30 if you're a female. Go down to the bottom one, which is the Foundation for the National Institutes of Health one, which is the US, and look at the grip strength there. 26 for men and 16 for women. So there is a big difference between how we measure sarcopenia if you live in the US, and some would say, yes, that's understandable, and the Europeans. And so there are some problems with measurement, different ones, but generally I think most people will go with the European version. So we look at gait speed and grip strength, and in one of the studies that I'll mention to you, they didn't do DEXA to measure body mass, muscle mass. They actually used mid-upper arm muscle circumference, which is a little bit easier to do than putting everyone through a DEXA. Although if you ever get the opportunity to have your body mass composition done on a DEXA, do it. It's a real eye-opener. I kept mine quiet, but it's funny how much fat you've got where you don't realise you have fat. It's good. It's good to do it. Anyway, so the difficulties with measuring it, what population are you looking at? Are you looking at the Dutch? Because I can tell you we did a study of late middle-aged Dutch people, and none of them were sarcopenic using the US normal values. But quite a few of them were sarcopenic if you use the European values. So yeah, it's interesting. Depends if you use DEXA, which is the gold standard, or what we call BIA, which is bioimpedance, which a lot of people may know about because you stand on a scale and it measures it actually measures the amount of water you have on board. It's not as accurate. So yeah, there's a few issues with measuring it, but I think the reality is that from about 30, we lose 1% of our body mass per year. And after you hit 75, it's about 2% of what you've got left. What is really interesting, though, is where you lose it from. So you think of all those young bodies with big backsides. So it goes from your backside into fat and hits your tummy. And if you think of older people's shapes, we go from having a really nice, perky butt to having it at the front instead of the back. And that's actually what happens. That they're normal, like age-related changes, if you're not an active person. So I think that the lesson is do your butt exercises and keep what you can. You don't often recognise that you're losing muscle because as that picture showed at the start, you replace muscle with fat. So we can't see it from outside. And it's unfortunate, but loss of muscle mass is probably inevitable. It goes with getting older because even lifelong athletes still have less muscle mass as they age. They still perform well, but it does decrease. And it's important to remember that muscle mass is not the same as muscle strength. You can have quite a bit of muscle mass, but if it's not good quality muscle, then you're not going to be able to have that, to be able to do things with what you've got. So appearances can be really deceptive. This lady, if anyone knows who she was, she's dead now. You look at her in the left-hand picture and you'd say, no, she's frail, she's sarcopenic. And then you look at her in the right-hand picture, going to win the 100-year-old javelin throwing world record, which she still holds. She's died, but she was still cycling on her stationary bike to within a few months of her death. So she might look frail and thin and sarcopenic, but she ain't. However, And I have to say, my husband nicked my picture of sarcopenic obesity, so I had to find another one. But this, yeah, just in case you didn't realise I'm actually married to him, which is why we do a lot of work together. But sarcopenic obesity is really, really important. And in fact, in the FIT study that Ian mentioned, the frailty intervention trial, we had a number of patients who were really overweight, and we got them to lose weight, so they weren't having to lift as much weight when they got out of a chair. And it is quite important. And in fact, the lady whose video you saw was she had sarcopenic obesity, but by the time we finished, her muscles, as you saw, that smile on her face as she got out of that chair, she had really improved with her exercise and a little bit of weight loss. So don't think just because someone's fat, they're not sarcopenic. Why is muscle important? Well, it's obviously important because it moves us, but you have to remember all the other important things that muscle does. It's a major source of protein and energy in times of stress and malnutrition. And you know, if you're sick and you're in bed, you don't eat your fat, you eat your muscle. Which is why when we put older people to bed, they lose muscle mass, and I'll come to that a bit later. But it's quite important as a, if you like, your backstop. It regulates glucose levels. So again, low muscle mass or poor muscle, more likely to get type 2 diabetes, and increased drug toxicity if you've got less muscle mass, and also hormone homeostasis, so equilibrating the hormones in your blood. So muscle's good for lots of things, not just moving us. How common is it? And I think you're going to hear a little bit about the CHAMP study, which is the Concord study that Vasi will be talking about in the next session. But if you look at, and they use the NIH, so the American definition of sarcopenia, 14% had sarcopenia if you used muscle mass, 5% if you used muscle mass and weakness on hand grip strength, and 4% if you used muscle mass and weakness and a slow gait speed. And 0.8 of a metre per second is pretty slow. You're not going to get across a pedestrian crossing with the lights if you walk that slowly. In Europe, it's interesting. If you use, they've got some cut-offs. If you use the highest, it's about 11%. If you use the lowest, it's 20%. And that's older people, that's people over the age of 65. In CHAMP, it was over 70. So you've just got to ask, and how old are these people when you look at it? But you know, there's a bit of sarcopenia around. I think that's what's important. What are the causes? I've already mentioned age, because we lose it 1% per year. Lack of exercise. You know, couch potatoes are going to become sarcopenic. But there are other factors, the pro-inflammatory factors, the things that maybe are involved with everything from Alzheimer's disease to stroke. Interleukin-6 is produced in both acute and chronic disease, and more in older age, and it's really important because you can reduce the levels by exercising, particularly resistance training. I'll come to that. The satellite cell function, so your satellite cells are sort of what, in a way, a bit like the stem cells of your muscle. They decrease as you get older, or due to illness, or due to chemotherapy, or maybe due to something like steroids, prednisone, things like that. We also think that the little powerhouses of the cell, the mitochondria, start to function badly, and that probably results in lower gait speed. And then there's smoking, various medical comorbidities that I've mentioned, vitamin D deficiency, don't forget that, and obesity are all contributing to sarcopenia. So as you can see, we can't do much about age, but we can do a lot about everything else. This is just if you're diagram of the causes of sarcopenia, and I don't expect you to look at it in detail, but what it does show you is that you've got your age-related stuff, you've got vascular causes, you've got the hormones, so low testosterone, low estrogen, low vitamin D, and high cortisol, so that's the prednisone effect, your pro-inflammatory cytokines that I mentioned, and weight loss, dieting, or unintentional dieting, which a lot of older people do, which is why nutrition is just going to be so important in this. And then there's probably some nerve changes that also impact on muscle and increase your loss of muscle. So what are the consequences of sarcopenia? I think probably they're pretty obvious if you think about it. But in terms of if your muscle strength's low, then you're going to walk slowly. You've got an increased risk of falls, and I'll show you the few studies that have been done that show you how much, and you don't function as well in activities of daily living. I think that's obvious. But what is interesting is all the other things that go with it. So increased chance of going into hospital, I guess partly because you fall, but also because you're just not so well. Increased chance of going into residential care, of requiring that sort of care. You don't recover so well after surgery. Higher drug toxicity because you haven't got as much muscle for the drugs to go into. Development of frailty, and I think the interlinking of frailty and sarcopenia is shown on the screen in the corner there, and an increased risk of death because you are not as well as you could be. And the diagram in the corner does show that there is a real overlap between sarcopenia and frailty, but you can be sarcopenic and not frail, which is interesting, and frail and not sarcopenic. I think the overlap's a bit more than it looks like here, but this is just diagrammatic. So, sarcopenia and falls. If you use the European definition, and this was an Italian study that actually looked very carefully at sarcopenia and falls, about 260 older people, and they were 80 plus. So they were your older people living at home, so these were community dwelling older people. 25% of them were sarcopenic, and it didn't seem to matter if they were male or female, it was equal. 27% of those with sarcopenia fell, 10% of those without sarcopenia fell, and they had very good follow-up. They followed them up every month for 2 years, so they pretty much got all the falls. And what they found is you are 3 times more likely, 3.2 if you want to, times more likely to fall if you're sarcopenic, and that's adjusting for age and gender and a whole stack of other things, comorbidities. Sarcopenia on its own was a really potent cause of falls or a risk factor for falls. In the study of osteoporotic fractures, which is a study in the US, and this was looking at 5,800 plus, it was actually older men, not just older people, men over the age of 65. They used again, the European definition, that you were 2.5 times as likely to fall if you were sarcopenic. And they had quite good follow-up, but that was over 1 year. So I think it's pretty obvious that the loss of muscle mass and strength and the loss of physical function and performance that goes along with it is why people with sarcopenia fall more. And I think we need to be thinking about that when we talk about falls. We talk about muscle strength the whole time, but if we actually think about sarcopenia, it also makes you think about something else, which I'll talk about in a minute. Now, I mentioned sarcopenia and bed rest before. More than a day of going to bed is bad for you, no matter what your age. Many, many years ago, when I was at Concord Hospital as an intern in the late 70s, we did a study with a lady called Jan Webster, who was then the head physiotherapist, where we got a whole lot of young male soldiers, volunteers, and put them to bed for 5 days, and they weren't allowed to come up above 45 degrees. They thought it was wonderful. They could play cards, they were fed. And we'd measured the muscle strength, particularly lower limb, on the Sunday. Friday afternoon, when they measured the muscle strength, the drop was so drastic, the study stopped then and there. It was amazing. And these were young guys. And it stuck with me that I just happened to be the intern on the ward, just how dangerous putting someone to bed. And they're perfectly well, how dangerous it can be. Older people, when you put them to bed, lose muscle mass probably twice the rate, maybe 3 times the rate of younger people. And that's important too, because as I said, when you put to bed, and goodness knows we really starve people in hospital, and apparently 1 person per month dies purely of malnutrition in New South Wales hospitals. It was I don't know how valid that is, but when you look at how little they eat, it's not surprising. But as I said, when you're in bed, you eat your muscle, not your fat. I suppose you eat your fat when there's no muscle left, but it is important. So bed rest leads to insulin resistance, and you can't easily, if you're immobile, you don't use your protein that you do eat as well as you could. And we know that resistance training and mobilising, even just standing someone up, and they do that in ICU now 2 or 3 times a day, simply to get people's posture upright for a short period of time, maybe on a tilt table even. That can be really important. And supplementation with protein. And I'll talk about this again in a minute, but it's basically whey protein isolate. Now that's what all the gym junkies use. A lot of runners use it, a lot of endurance people use it. When my daughter was staying with me, I found a large tub of this in our pantry. And it's just a scoop in your iced coffee or your chocolate milk after you've had your run. Really easy. A scoop is 20 grams, which is what we're meant to give older people 3 times a day, and it's already leucine enriched. Leucine is one of the essential amino acids that's really, really important to build muscle. So it's quite simple what we have to do, but it's a lot harder to implement than you would think. And I'm really pleased. I know there's at least one dietitian in the audience, maybe more, because this is such an important area. Now, how do we assess for sarcopenia? And Ian talked about John Morley, who is quite a well-known geriatrician who started in South Africa, then went to Adelaide, and then the grass was obviously very green in St. Louis, and he is now in the US. But he has been an absolute evangelist when it comes to sarcopenia and frailty. And this is another of his back of envelope or having a drink and written on the table napkin. But this is how you can ask about sarcopenia without having to do a lot of measurements. The SARC-F, you can look it up, it's freely available. It's how much can you lift 10 pounds? Now, that's obviously the American version. I just say to people, how can you lift a supermarket bag with a couple of litres of milk and fruit in it? And you'll find people can't even lift. They'll say, oh, you know, I have trouble lifting even a bag with a litre of milk in it. And interestingly, not so long ago in the supermarket at Coles, I actually saw an older lady saying to the man, can you put them just in separate bags? And she sort of said, because I can't lift them otherwise. So she was lifting them one at a time, and it was like 3 kilos max, so that would not even be 10 pounds. Assistance in walking, can you walk across a room? Can you get out of a chair? Can you go up a flight of stairs? And have you had any falls? So it's there, but that's what you're looking at. And that matches really well. It's validated in US populations, because that's where John Morley works, but also in Asia. There's been quite a lot of work done in Singapore and Hong Kong by John with colleagues, and we haven't done it here. But I think there's no reason to expect that it wouldn't be reasonably valid here. And the comment from the Swedish author who was looking at it was that it is appropriate for detecting patients at risk of adverse outcomes, and hospitalisation and death are just 2 of those adverse outcomes, but I think we can also be using it obviously for falls. So how do we treat it? The big treatment we've always thought about, and you will see the similarity obviously with falls, is progressive resistance training, 3 sessions a week of the main muscle groups. And that can be all sorts of ways. You're going to hear this afternoon from Jenny Hewitt. They used machines, gym machines, but it's perfectly reasonable. And these pictures at the bottom, some of them are from our frailty intervention trial. You use what you've already got. So sit to stand, you're using your body weight. It is a really, really, really good exercise, and we should all be doing it. You should all be able to do 20 to start with, then go up to 50, and we certainly do it at work. You're using the 3 big muscle groups in your body: your gluteal muscles, your hamstrings, and your quads, and it's really good, and it's good for balance as well. And that's, I guess, important in terms of falls. But why do we do resistance training? Because it reduces those pro-inflammatory cytokines. So you're not just improving your muscles, it's really good for your brain, and we know that resistance training is good in the prevention of certainly Alzheimer's disease and vascular dementia, and probably a number of other diseases. It does get those stem cells, the satellite cells, going. It obviously improves blood flow, and it decreases oxidative stress, which is basically rust, because if you don't move, you will rust. You know, people say to me, yeah, I'd prefer to wear out than rust out. And I think that's what it is. It's oxidation that's not good. So the next one is nutrition, and I really want you to take this on board because this is so important when we're looking at falls now. For younger people, the adults generally, it's the recommendation for protein intake per day is about 0.8 of a gram per kilogram per day, so 60, 70 grams of protein. When you get to older age, so probably over the age of 65, you're looking at 1.5 grams per day, unless you've got kidney failure, and hopefully there's very few of those, you're looking at 1.5 grams of protein per day. So that's you know, a good 100 grams of protein a day for someone who weighs 60 or 70 kilos. And the whey protein isolate that's enriched with leucine is the easiest way to go. And the other thing that's been shown to improve sarcopenia is omega-3 fatty acids. We know they're quite good for joints and probably for the brain because that's what the brain uses to repair itself, but there's also evidence for them with this. And I suggest, and we've been doing it now for about 2.5 years, is people have a scoop of whey protein isolate, so just the 5 minutes, yep, you get the tub, it's got a scoop in it, you just add that to iced coffee or milk, or it's nicest in iced coffee and chocolate milk, I can tell you that from experience. And it's very easy to take. And then medications, vitamin D, do not forget vitamin D, it comes up again and again and again, that's really important. There is very good evidence to make sure someone is vitamin D replete, so at least a level of around 75. There are a few other medical medications which are interesting. The anabolic steroids, we're not using them much, but in the old days we used to give older ladies Decadurabolon, and they really loved it, except it did give them hairy arms and a deep voice. But it did work, and you know, I kid you not, it was quite a popular treatment because people did feel stronger on it. Hormones, there's some evidence for that. There's the myostatin inhibitors, which we've done some drug trials in, and as one of my colleagues said, wouldn't it be fun just to be able to take a tablet instead of having to exercise? But probably not. ACE inhibitors. There is some evidence that, you know, the blood pressure lowering medications somehow improve muscle function. And there's been randomised trials recently which didn't show they work, but that was in healthy older people. It seems if you're 75 plus and not 100% well, therefore probably a bit sarcopenic, they do work better to improve muscle strength and function. So it's quite interesting. And I put this up. This is my message for today. Management of falls in older people should include attention to nutrition. Think about it. Think about it. Because if an older person's got sarcopenia, then that's contributing to their falls risk, and exercise alone is not enough. And I think that's really important. Think of the 1.5 grams per kilogram per day, and I just say, look, referral to a dietitian is essential if you think someone's sarcopenic, and probably important in most cases. And I draw your attention to the fact that April Falls Month looked at what? Nutrition and hydration. So I think it's important that we really follow that on and continue that message. Finally, I just want to say it's never too late. This is Ruth Frith again. She took up exercise at 75 because I think she had trouble getting out of a chair, and then went on to hold 4 world records. So you're never too old. Are we fated to lose muscle mass? And I say we because I look around the room and think, yep, we're all getting older. Yes, we are, but, and we'll lose it even if we do exercise a lot, but we can markedly ameliorate the changes by appropriate exercise and making sure we're getting enough protein. I think that's really important. And I'll just leave the last words to first someone from the past, Hippocrates, who said very definitely, you need to use all the bits of your body, and the last 2 lines, but if unused and left idle, they become liable to disease, defective in growth, and age quickly. And then John Morley, I've mentioned already. This is John. He says, it is time for physicians, and I think it's not just physicians, but it's time for everybody to screen for sarcopenia and provide treatment. At a minimum, resistance exercise, protein, and vitamin D supplementation. Easy. Thank you.
Excellent. Thank you very much, Sue. That was fantastic. Here's a gift from the...
Thank you.
Thank you. And I believe Ingrid's going to come and do a Slido at this stage.
Thanks, Kathy. We do have one more poll that we're running now, and this question is, what new information have you learnt from this presentation from Sue this morning? And it's going to be a word jumble, so if you just put in a couple of words, please. And I'll just bring it up. Sue, there was one question in here that I thought was really good. If people are short of time, clinicians, do you think they're better to screen for frailty or for sarcopenia?
This could be divorce material. Look, I think frailty, but you need to then, if their muscle strength is low, you say, hello, there's sarcopenia, and think that way. But it's being aware that it's there and thinking nutrition. And yep, it's good to see the protein and exercise nutrition. Whey, good whey protein, excellent.
Yes, great. So I think everyone's got the messages from Sue's presentation. I'd just like to also note, for everyone that's asking the questions, thank you so much. If we can't answer them today, just due to lack of time, we'll answer them through the Falls Network. There's been a number of questions on the FIT trial, and we'll get that up on the Falls Network, and then hopefully get to all of these over the next week or so. Thank you.
Thank you. Excellent. So it's my pleasure now to introduce the next speaker. And so this is Associate Professor Vasi Naganathan. And Vasi is a consultant geriatrician at Concord Hospital and the Centre for Education and Research on Ageing at the University of Sydney. And he's particularly interested in the health of older men with his research as well as other things. So please join me in welcoming Vasi.
Thank you, Kathy. So apparently men and women are different. So they tell me. And the question is, when it comes to falls, is there some difference between men and women? And this is my first, I've been involved with the CHAMP study for a long time, but this is the first time I've had to talk about this publicly, about the question about whether falls is different. So I didn't prepare for this using the net facility, so I'll just ask you the old-fashioned way. So what do you all think who are working in the field? Is there, when it comes to risk factors, when it comes to the types of interventions, when it comes to compliance, what do you think? Is there a gender difference? And can I have throw some thoughts at me? What are the differences? There isn't a right answer here, but I'm interested in your views, because preparing for this talk made me think about my own thoughts. Just throw out some of your thoughts. What are the differences? Compliance, and I assume you mean us blokes are less compliant? Yep. Men take more risk. Men accept the risk. Men are more likely to just accept the risk. Is that? Yes? Yep. Denial. We're not looking good here. Do you want to say more about that?
Well, I think it might be like that men may engage in risky behaviour such as climbing up ladders and those type of things.
Yep.
And women may engage in behaviour such as going to the toilet unaccompanied when asked to do so because they don't know whatever it is.
Yep.
I just think they might both engage in risk, but they might engage in types of risk.
And therefore, can anyone think, just in your everyday practice, when talking to, do you therefore tailor your message with men and women? Yep. And do you think that tailoring is based on gender or more that particular person? So I think that's, so with all that in mind, which are all the questions I had and thoughts I had, I then went through a bit on the evidence, what's out there, and a bit on our CHAMP study. So for my talk, I'm going to first talk about our study of older men called the CHAMP study. I'm going to address some of the questions which are, is there anything particular about men and risk factors for falls? What do we know from the falls trials? A bit about fear of falling, and a few of you have already mentioned the fact that we have a feeling that men are more likely to take risks, and willingness to engage in falls prevention strategies. And then in light of Ian and Sue's talk, and with the CHAMP study in mind, falls as part of the bigger picture, if you like. So to tell you a bit about the CHAMP study. So the CHAMP study is a study that enrolled men aged above 70, and what we wanted to do was get a representative sample of people, and we had a number of investigators on that study. Not all geriatricians, we had endocrinologists, osteoporosis experts, public health experts, and a lot of what I'm going to talk about when it comes to the CHAMP study was work done by Nicola Boyle. That's a picture of her there, who is a geriatrician who worked with us for a while and did a PhD under my supervision. She's now back home in Ireland, doing great things there. So, study of older men from the local government areas of Burwood, Canada Bay and Strathfield, living in the community, so not from residential care. We sampled the electoral roll and approached men by phone calls and mailing. And we followed up men now for 2, 5 and 8 years. And for a long period of time, they actually had 4 monthly phone calls, which is how we found out about their falls. And we also have linked to New South Wales health data. And the thing about CHAMP is it collected a lot of data. And it was actually face-to-face data as well as self-completed questionnaires. And so with falls in mind, if I pick out some of the things there, we asked about medications, and we actually asked them to bring their bag of medications in. We asked all about their health. We used the Freed criteria for frailty, which Ian spoke about. And then in terms of physical measures, we did test of balance, grip strength, chair stands, walking speed, and of course asked them about a history of falls. But it was part of our overall thing about looking at their health. And one of the particular strengths about CHAMP is we actually looked, at least at baseline, at their cognition. So they actually had the mini mental state as a screening tool, but also a questionnaire that we asked an informant, so someone that we could ask about their cognition, often their partner or one of their children. And then if they were positive on this screening, they actually got seen by a geriatrician, and then 3 people got together and made a decision on their cognitive status. That gives you an idea of the numbers. So we started with 1,700 men. And there's the age distribution of the CHAMP population, which pretty matches what we know about those 3 government areas. So a reasonably representative group of men. And as you'd expect from, if you like, the inner part of Sydney, a high proportion of men born outside Australia. And with that in mind, what do you think? Did you think the Italian-born men fall more, the same? Yes. All right. Yep. I'll give you the answer at the end. So this is generally in the literature. Men fall less, right? So the prevalence is thought to be about half in community studies. So when they go in and ask people, have you had a fall in the last 12 months? In men, it seems about half that of women. But when you look at New South Wales health data, there is an increase in the admissions due to fall injuries that have been increasing in both men and women over time, even when you match for age. And that's curious, and we can possibly have a discussion about why that might be. We've known from the osteoporosis literature that women are more likely to fracture from a fall. They are more likely to injure themselves from a fall. And if you look at the proportion of people in hospital due to falls injury, it's about 2/3 female. The only difference, and maybe that goes to falling off ladders theory, that is that men have a higher rate of intracranial injuries, so head injuries from falls, presumably from falls. And in the CHAMP study, when we asked men at baseline, had you fallen in the last 12 months, that's the results we got. So 19% reported just one fall, and 9%, so almost 10%, had 2 or more falls. In studies that have looked at men and women and quantified, if you like, their risk factors for falling, this slide gives you, this is a meta-analysis that looked at, this gives you an idea of the risk factors for fall and, if you like, how they match up against each other. So being female increases your risk of falling, but not as much as having a history of falls, having cognitive impairment, having physical disability, and in fact, not quite as much as being on sedative medications. So in a way, from a population perspective, I think that meta-analysis gives you some perspective of where gender fits in relationship to all the other known risk factors for falling. So in a way, we should put that in its perspective. If you look at all the individual studies, there has been, some people have said that maybe psychotropic medications are not as big a risk factor for falls in men, but it could be that men are less likely to be on psychotropic medications when you look at the studies that have had men and women, and so it could just be a power thing rather than a real effect. People have also tried to tease out whether, on the various physical measures of balance and strength, whether there are gender differences in how it relates to fall. But when you look at the studies put together, there's no real consistency in that. So my view would be that you can't really jump to any conclusions and say, these are the better measures of physical strength and balance to do in men compared to women. And let's look at our CHAMP. So this is from the CHAMP study. So this is looking at the risk factors for fall over 2 years. And the big one that comes out is the simple one, which is the history of falls, right? Which increased the risk by 3 times for the rate of falls and by almost 6 times in terms of the risk of falls. Age is there. You're right about the Italian men. They are less, their risk of falling is less. Social satisfaction was the men's perception of their social contacts. So isolation seemed to be a risk factor for fall. More than 3 comorbidities, visual acuity, and dementia and polypharmacy in only 1 of the 2 major outcomes. So that was in terms of the rates of falls. What's missing there is actually the physical measures, you'll notice, right? So we did all those physical measures. And that's hard to interpret, but I guess my take on that would be, and actually was shown in the analysis, is that the history of falls is such a dominant risk factor that it probably does incorporate the frailty, the ADL disability, the decreased physical strength. That's probably all caught up in that history of falls. Right? So if you compare fallers to non-fallers, it's clear that they are frailer and decreased physical strength. So in our regression models, in our analysis, it dominates. And so the other things don't show up as being significant in our models. But it does show of asking that simple question about history of falls. And here's the comparison between Italian-born men and Australian-born men. So they do report less falls, less previous fractures, and even in follow-up, report less falls. Now, that could be that Italian men, or maybe their wives, are likely to report falls, or it is a true phenomenon that they fall less. When we look at, and this might answer that question. So, as I said, we linked the CHAMP men to hospital data, and we actually were able to track admissions to hospital stays in hospital due to fall, not just coming to the emergency department, but being admitted to hospital with a fall injury. So over 10 years of follow-up, 17% of men had at least 1 admission with a fall injury, And the risk factors for that were, and they're almost in order here, dementia as the biggest risk factor, being born in an English-speaking country, grip strength, slow walking speed, polypharmacy, age, and history of falls. So once you start looking at injuries, the risk factor, at least the order, starts to change a bit. And it's hard to know what that means, whether grip strength and walking speed become a bit more important in terms of protection when you fall, and therefore the way you fall, and possibly influences prevention of fractures. The fact that the Italian-born men were less likely to get fall injuries, which is consistent with New South Wales health data, suggests that it's not a reporting problem, right? It wasn't that simply, Italian bravado, hey, I don't fall. That's not it. Here's our data on risk factors for hip fracture, and you can see the influence of dementia on there, right? So I like showing this to the endocrinologists, right, and the osteoporosis fraternity. Right? I love showing them this slide because it shows you the importance of the brain, right, which they ignore basically. But having said that, if they want to throw that back at me, they could say, because I've always wondered, as people get frail and have risk factors for falling, and maybe falls becomes the dominant thing and your bone density doesn't matter as much. But actually, this study shows that even when you account for frailty in this older group of people, that number of bone density of 2 for each standard deviation fall in bone density is what's been shown in the younger population as well. So bone density still comes up strong. So that keeps them happy when I say that. We've talked about vitamin D, and this is interesting that we showed this in the CHAMP study. It shows this U-shaped relationship between vitamin D and fracture. So it makes sense, the men who had the lowest levels of vitamin D had more fractures, but bizarrely, those who had the highest level of vitamin D also had higher risk of fracture. Now, if we didn't know that 2 randomized trials have also shown that high-dose vitamin D seemed to increase the risk of fracture, we would have looked at this and go, that's just a chance finding. But it's interesting that this matches up with 2 big trials that have shown that super doses of vitamin D actually increase the risk of fracture. So it's hard to know what that means, but maybe too much of a good thing is not so good. This is a different cohort of people, and I just wanted to look at the gender thing. So this is 500 people who came to the emergency department with a fall or a fall-related injury at Concord Hospital. And we followed them up as best we could for the next 5 years. So this is, you can imagine, a frail group with lots of comorbidity. 50% mortality over 5 years. Even keeping that in mind, 41% still came back to the emergency department at least once over the next 5 years. The risk factors for representing were age over 80, disability in ADLs and or comorbidities, but gender didn't make a difference. And it's probably because their frailty, their comorbidities, their illnesses, their risk factor for falls, that's the dominant thing. So once you've got that degree of risk factors for falls, gender really doesn't make much of a difference to this group of people's risk. Now the question of falls trials. Now I have to confess this has been my first week of thinking about this in terms of falls trials, and I haven't really gone through it in great detail. But the truth is that, say, if we look at the Cochrane review from 2012 and go through the falls trials, the multifactorial intervention trials, so there were 34 of those trials, and the median proportion of female in those trials was 70%. There were some trials which had no men, but most of them, when you look at it, it varies roughly between 20 to 40% of men in the trials. And there were only 2 trials just done in males. One was a veterans hospital. And they're small trials, and perhaps not surprisingly, they were negative in terms of their results. So it'd be interesting when Kathy's doing her meta-analysis of the exercise trials, what proportion of the trials include men, and then if there's large enough numbers, whether you can look at whether the effect varies between men and women, whether the effect varies and whether compliance varies when you actually look at the trial data. And I'm not aware of anyone actually looking at that simple question about, are men less compliant in those falls trials? Is it more if certain forms of interventions, such as certain forms of exercise, more effective in men than women, or vice versa? Fear of falling. In the studies, my understanding of the studies that have looked at fear of falling is reported more by women than men. So if that's the case, as we touched on early on, does it mean that males will be less careful? Does it mean they're less likely to self-restrict their activity, which is one of the consequences of fear of falling that has been shown? And does that influence compliance with fall prevention strategies? And the quote down there is from a qualitative study that I found, which says that women in general were more sensible about protecting themselves from falls and were more concerned about the consequences of falls, which is what many of you feel anecdotally. That's what you see in the real world, in your everyday practice. But actually, so it then raises this question. So do we have data about exercise programs, medication programs? I wonder if the Stepping On program actually keeps data about, well, it should have data about the gender differences in terms of both attendance, right? So you'd expect, from what we know about the prevalence of falls, roughly to go, 2/3 to 1/3. But is that what they actually find in terms of people enrolling in Stepping On programs? This is the closest I could find to answering this question. And in the individual study discussions and the systematic reviews, actually gender doesn't come up, right? People don't write much about whether there's a difference in compliance with fall prevention strategies between men and women. So this systematic review identified, as you can see there, the various facilitators, which I think you'd all agree are the things that you would find in your everyday life, right? The importance of social support as part of the intervention, having experience in exercising, greater education, involvement in decision-making, and then the barriers that you find there. So it could be, which we talked about, it could be that the individual variation matters more than thinking about in terms of gender differences. So you'll see men and women, right, with a variety of perceptions about falls prevention strategies. And that might be the take-home message, rather than, men think this way about it and women think this way about it. But I don't think it's actually been studied that closely. We did find this in the CHAMP study, which makes us think about falls prevention. So this is at baseline. More than 15% had seen a physiotherapist in the last month. And if they were frail, disabled, or both frail and disabled, they were more likely to have seen a therapist in the previous 12 months. And one of the questions then, which we won't be able to answer from our study, is, was falls prevention discussed? Did people ask them, had you fallen in the last previous 12 months? Now, a bit more about falls as the bigger picture. The prevalence of falls and the incidence of falls goes up along with the other geriatric syndromes such as immobility, incontinence, and dementia. And there is something about, being above 80. So, many of us talk about the old, right? Because there's something about the old that they're more likely to have the geriatric syndromes, more likely to be frail, more likely to benefit from a comprehensive assessment. And you can see that for falls, and it just tracks with all the other geriatric syndromes. And the same with incidence. So this is taking people at baseline, so that's their age at baseline, and looking at who got a new syndrome over the next 5 years. This is another way to present that. So look at the 80 to 84 column, and you can look at this in two ways, right? Who went the next 5 years without getting recurrent falls or one of the other geriatric syndromes? And it's about 50% who didn't get them, and 50% did. So it depends whether you're talking to an audience about falls prevention or you're talking to an audience about healthy aging, about which way you'll interpret that data. I think someone mentioned urinary symptoms, and actually I think you mentioned in the context of women with urinary incontinence and that being a risk factor for falling. So we looked at that, though, in men, and we actually showed that incontinence and even having lower urinary tract symptoms based on a standardized scoring system was a risk factor for falling. Now, it's not clear whether it's the incontinence and the process of dealing with incontinence and rushing to the toilet, that's what's increasing the risk of falling, or it's what goes with having those urinary tract symptoms. So if you have those urinary tract symptoms, you're more likely to have comorbidity, more likely to be frail, and even when we've adjusted for it in our models. So we can't really tease that out. You know, the real question is, if you ask men who've fallen, what proportion report falling because they were rushing to the toilet, right? That's really the way you'd get that answer. On the question of nutrition, so this is in our 5-year follow-up, this is the proportion of men who met the Australian guidelines for the various food groups there. And you can see that the men around Concord don't like their veggies, right? Despite having the Italian-born men there, right? And whole grains and dairy. And that dairy thing probably fits when we look at some of the more micronutrients. Look at this is meeting the nutrient reference values for vitamin D and calcium, right? You can see particularly vitamin D and calcium, how low that is. And then on the question of frailty, so we looked at the prevalence of frailty using both the frailty index, which Ian spoke about, and the Fried frailty syndrome, and you can see how the prevalence increases with increasing age groups. That all makes sense. I had to do a review on frailty, and I came across this. So in the UK NHS contracts for general practitioners, one of the things they put in is that you need to get a frailty index. And with the general practice software, it's actually, general practice in England have great software databases where basically they put all the comorbidities in. So it's just a tweak of the software that it can create a frailty index or a frailty score. And almost mandatory for the GPs is to do that. In people who are at the highest levels of frailty, they then need to have a screening to work out whether they're really frail. And if they are and deemed to be severe frailty, they've got to ask the question about, have you had a fall in the last 12 months? And then act accordingly. I must say, I haven't talked to anyone in the UK, but the obvious question is, why can't you just ask people when they come in for the consultation, have you had a fall in the last 12 months? And in fact, I think some of the CHAMP data would actually support that, right, about the importance of asking that simple question. So my concluding thoughts, the risk of falls and falls-related injury in men are not as high in women, but they're not so low or anywhere near so low that you can actually worry less. There are no startling and consistent differences in terms of risk factors. We have no proof that falls prevention strategies should be different in men and women and work differently, but it would be fair to say we haven't necessarily looked at that closely. It's important to see falls as part of the geriatric syndrome and part of the bigger picture. And it's unclear if gender on its own, and I'd argue that there actually isn't evidence at all, that should be a big factor in how you think about getting people to engage in falls prevention strategies. It is, as we discuss, more focus on the individual and what their perceptions are, rather than coming, if you like, to any gender stereotypes. And this is the most important slide, and I'll get you to read this slowly, and it's not true that my wife slipped this in, but I did find this when I was doing my search this week. Thank you.
Thank you very much, Fazi. That was a very informative talk. We're going to have questions at the end of this session. So it's now my pleasure to introduce our next speaker, Miss Anne Kalra, who's the team leader for health and wellbeing of independent living at the Uniting Retirement Villages. And there's some more information on her bio in the program. So welcome. Thank you very much. Just get your talk up and running.
Thank you. Thank you, Professor Sherrington, and thank you, everyone. It is an honor to be here and present. My name is Anne Kalra, and I'm from Uniting. My role within Uniting is that of team of health and well-being across 80 retirement villages of Uniting in New South Wales and ACT. I'm a dementia consultant and an aged care consultant. I'm here to talk about falls, not a normal part of aging, and building sustainability into a strength and balance program in Uniting's retirement villages. Just a little information on our retirement villages. The median age for our residents is around 75 to 80 years, and the entry age is anything 55 plus. Before I start, I also would like to give you some background information on Uniting. Uniting is a leading provider in aged care services in community, retirement living, and residential aged care facilities. As of 25th November 2015, we are called Uniting instead of Uniting Care. As an organization, we go an extra mile for making a positive difference in people's lives we serve. At Uniting, we have a strong commitment in engaging with culturally diverse organizations and providing services to people from all backgrounds. We have 8,000 staff, 30,000 clients, and 3,000 volunteers. We have 80 retirement villages across New South Wales and ACT. Coming back to the topic of my presentation, at Uniting, we have an organizational focus on positive aging and making all our programs on positive aging sustainable. I'm sharing with you all here today what we have put into practice from a ground level now that we have heard all the experts this morning. For a number of years, we had brought falls prevention programs called Stepping On programs in our various villages across New South Wales. And I must admit, all our work was very sporadic. We realized that we needed a three-pronged approach in achieving sustainability for Strength and Balance program. And we took certain steps for that. We adopted a holistic approach towards Strength and Balance program. And we took three major steps in achieving this. Number one, we provided seniors with consistent message at each monthly resident meeting. Our message was pretty simple. Exercise is important to maintain the physical fitness of the body and for them to remain independent. And that exercise keeps some lifestyle-associated diseases at bay, such as osteoporosis, heart disease, type 2 diabetes. Our message was simple: use it or lose it. We adopted a broad, healthy aging and wellness approach, rather than funding one-off programs that focus on specific issues in specific settings. Number two, we shared evidence-based studies with our seniors that highlighted that one of the greatest long-term threats to our ability to remain healthy and function independently with advancing age is a steady loss of lean muscle mass, a condition called sarcopenia, as Professor Curl has mentioned, which is a loss of muscle mass and strength related with age that not only impacts elderly persons' abilities to perform even the most basic tasks of daily living, but also heightens the risk of sudden falls and other accidents. We adopted an integrated approach to educate our seniors about prevention of loss of muscle mass and in understanding about sarcopenia, and that it can be prevented by remaining physically active. At our resident monthly meetings, we share with the residents information and evidence-based studies on main risk factors for falls amongst older people. Risk factors such as medical conditions, circulatory disease, chronic obstructive pulmonary disease, depression, arthritis, and how each of these conditions are associated with the increased risk of falls. We talk about thyroid dysfunction, leading to excess circulating thyroid hormone, diabetes, and arthritis, leading to loss of peripheral sensation, also increases the risk of falls. We talk about the impact of impaired mobility and gait as we age, where activities of daily living can become difficult and then impossible to carry out, especially for those who have been sedentary most of their lives. We discuss at these meetings how life changes when strength, muscle power, and function declines, and one is unable to prevent a slip, trip, or a fall. Muscle weakness is a significant risk factor for falls, as is gait deficit and balance deficit. Nutritional deficiencies can cause malnutrition that leads to a low body mass index associated with increased falls risk. Vitamin D deficiency is particularly common in older people, not just in residential care facilities, but also older people living in their own homes, who stay mostly indoors for various health conditions that may lead to abnormal gait and muscle weakness in older people, again, increasing the falls risk factors. Visual impairments such as visual acuity, contrast sensitivity, cataract, glaucoma, macular degeneration, all contribute to risk of falls. Our message we give out to a resident is simple. If they experience any warning signs that something is not right, it is important for them to discuss any health concerns and falls that they may be having with their doctor, and our message is that falls are preventable. By sharing information with our seniors, we have been consciously working on changing the traditional model for providing information to seniors after they have had an illness and dependence through providing passive support for them. Instead now, we are focused on the concept of wellness and re-ablement and capacity building, whereby independence in performing activities of daily living and remaining active is encouraged and facilitated. This shift in focus produced more favorable outcomes for our seniors with improved wellness and through achieving greater independence. I would like to show a short video.
There's an underlying myth that falls are an inevitable part of getting old. The surprising truth is our risk of a fall decreases with this one simple thing: exercise. You see, starting at 30, our muscles can lose up to 8% of their strength every decade. So, by the time we're 80, we've potentially lost 40% of our strength. We can help reverse this trend, though, with 6 simple exercises widely used by physiotherapists to keep us mobile and independent as we age. All you need is a steady support, sensible shoes, and a little time each day. Exercise 1. Heel raises. Stand tall and hold your support. Then lift your heels off the floor, taking your weight through the front part of your feet. Hold this position for 3 seconds. Then slowly lower your heels to the floor. Repeat this 10 times. Exercise 2.
You have an idea. So these are 6 very, very simple exercises The point of showing this was that we have trialed different things in different retirement villages. Villages, we have where we had stepping on program. The program has been running so successfully that even when the 6 weeks of program got finished, the residents themselves saw the benefits of the strength and balance program, and they started paying the exercise physiologist whatever the exercise physiologist was charging, say $10 a session, and those programs are still continuing in our villages 5 years since the time they have finished. Few other villages. So residents have been driving the strength and balance program for the last 5 years. They have been paying the exercise physiologist. They felt they could afford to pay the exercise physiologist. In other villages, we have been doing it in a very simple manner. We are either playing this video clip. We have resident ambassadors that we have put through Train the Trainer program, and they are running these video clips on a weekly basis. The point is that it's sustainable and it is ongoing. For us, I do have to admit the biggest game changer was a simple change of approach, and that was a third step we took. We changed our approach from calling it from falls prevention to strength and balance program. Just a small step we took in changing our terminology played a huge part in improving our seniors' wellness in our retirement villages. We embedded the focus on active aging in the position description of support advisors and social activities position, which has a specific focus on facilitating enablement and also creative aging programs and building residents' strength and balance. Overall result of this approach has led to improvement in our residents' health and wellness, resident satisfaction with strength and balance programs, social engagement of residents, and I must say that it has also fostered friendship amongst people who look forward to group activities and meet other residents and have now made friendships. For the quieter ones, they have chosen the individual program of strength and balance, doing it in their own time and space, and they have found the fridge magnets to be very useful as a reminder to do the exercises. For us, as I always say, is it the end or is it just the beginning of a work that is focused on wellness approach, providing a sense of belonging and purpose to our residents, and things that have worked for us in gaining success towards this approach is keeping our message simple and having an organizational focus and embedding it in position descriptions of social activities role. I have been part of the Healthy Older People Partnership Program since its inception in 2014, and I have advocated its benefits to staff and residents of retirement villages, being the ambassador for the Strength and Balance program. For the next 5 years is to continue to build on this and take this partnership across to other retirement villages. I have recently recruited 4 social activities people in my health and well-being team, and their role is solely to work on creative aging programs for our residents of independent living, and to engage with residents and to develop strong relationships and rapport with them and to make them part of their journey for active aging to improve their health and wellness. Thank you.
Thank you very much. That was fantastic to see how we can really put these things into practice. So next, it's my pleasure. Oh, I think we're doing a Slido, Ingrid? Yeah.
We have one final poll for this morning. And so if you'd all be able to get your phones up and open up Slido, the question is, would you now consider promoting balance and strength exercises to people in your care or the people that you work with? Yes, is the overwhelming answer. That's great to see from all the evidence that's been presented this morning and from Anne's presentation. Great, thank you.
slides again. Fantastic, thank you. All right, so now we're going to hear from Lorraine Lovett, who we heard mentioned in the opening session. So as most of you would know, Lorraine is the lead of the New South Wales Falls Prevention Program at the Clinical Excellence Commission, and she has many years of experience and a wealth of expertise in all aspects of falls prevention. So today she's going to be talking about the falls in hospitals aspect of leading better value care. So welcome, Lorraine.
Thank you. January last year, the Ministry of Health determined that we were going to go through leading better value care, and Nigel spoke to you about the program of work there. And the CEC was tasked with looking at falls in hospital, and as he indicated this morning, there was some concern about the degree of injury that is sustained by older people in our care. And even though over the years we've done a lot of work, I think this has helped us to consolidate a little bit more and to be a little bit more focused. And the CEC is a quality and safety organisation. It's one of the pillars for New South Wales Health. And around that is how we're going to, with a change of focus, how we're going to engage with our clinicians to look at quality improvement. And what does that mean? And what are the skills that you require in looking at the work you do and looking at how we can work in simple ways and with little tests of change to drive improvement. So with that, we've begun to focus on a Falls in Hospital collaborative. We have a lead, Dr. Deborah Brown, who has had experience, and we are working on this model based on IHI Improvement Agency from the States. And the comment was just made then, and Anne talked about falls, and often I say, well, we don't really want falls in our title necessarily. What we want to do is start talking about in hospital keeping people safe in our care, and what does that mean? Because you know, and we don't need to go through that, there are many reasons why people are vulnerable for falling and other injuries, particularly pressure injury, risk for developing delirium if they haven't presented with it during their inpatient stays. But what we know about improving care is that we actually need to work around our leaders and developing leaders and having leadership. We need to look at our governance and our frameworks around that and how we're going to monitor work that demonstrates actually that we're driving change. We need to work with our experts and expert leads, and you are all here in this room, whether that be from nursing, medical or allied health or other disciplines. So we didn't talk about in allied health our social workers and our dietitians and so on, everyone that has an important part to play. And we also know, and we've talked about this a long time in many of our conferences and forums that we hold, that falls prevention really is everyone's business. So what we've done is done a review. As you'd know, we report incidents, adverse events on our incident information management system in our New South Wales Health Services. And when we did a review again of those incidents, we know that most falls occur at the bedside and in the bathroom, during toileting, when people are mobilising, and as Sue would quite often point out is, yes, that's why they fall, because that's where they are. And that's true. But also there are challenges around why are they falling at that time there. And we have a high number of falls that are actually unwitnessed. So we really don't know, in some cases, why they've fallen. Many patients or people in our care are confused and have poor mobility, and the numbers of patients with serious injury, such as head injury, is increasing. And that's been demonstrated in our data, and certainly in terms of admissions to hospital as well. But also when they do fall in our care, we're seeing an increasing level of head injury. So we needed to look at how we're going to put systems in place and work more around how we can identify people who are confused. And we know then if they're confused, automatically we know they are a high falls risk. So what are we going to do about intervening and putting appropriate intervention in place? Identifying delirium and implement a delirium pathway, and that's the work that we do working with ACI and the Care of the Confused Hospitalised Older People program of work. and provide care for people with dementia and delirium. There's a lot more work we can do to improve how we manage those people with dementia and delirium in our hospitals. Mobilisation is really important, and we've touched on that today that you've heard. And more particularly, and so what Sue was saying, the longer we keep people in bed, they become deconditioned. So we're sort of trying to look at get people up, keep them mobilising, get them up and mobilising, let them stand from the chair that they're sitting in, walk them to the end of the bed, sit them down again. And can they do that safely? And you would know, those of you who've been with us last year, that we did some promotion around safe mobilisation, and we have information available on our CEC website with some videos around safe mobilisation as well. And we do certainly need to monitor some of the medications that we know are the culprit medications. So through this collaborative process, we developed this breakthrough series on building on what it takes to change it in a new system, sharing ideas for improvement, and by those sharing ideas, that's actually engaging with our clinicians. What is happening for you on your ward at this time? What do you think would make a change? What are the little bits of improvements that we could consider? And then support that process, which we're doing through the CEC, and I'll explain to you shortly. So the IIHI Breakthrough Model Series is this whole process of what's the expert knowledge, how are we going to develop a framework for change, and then looking at how we develop quality improvement through doing little plan, do, study, act cycles. What are we trying to accomplish? How will we know that a change is an improvement? And what kind of change can we make that would be sustainable as a result of that improvement? And that's just an example of little tests of change. So we are trying to keep older people safe in our care, and I'll come back to the PDSA cycles as well. How many in the room here are involved with us in the collaborative? Quite a few of you. So I'd want to acknowledge the fact that we know that involved in this work, it's been a hard call for many of you. It's an extra commitment to the day-to-day work that you've been doing. And in this little process of what we're talking in terms of driving that quality improvement, you're using new methodologies, and it actually has meant that different technology and different ways of collecting data, and still within some of our teams, there's some uncertainty about what that really means. But it's a 12-month process. We will have 4 one-day learning sets. So we've had 2, and we're about to go into our 3rd learning set on the 30th of May. We have 42 multidisciplinary clinical teams across the state, our health services. It is a focus on key interventions with a change and how we're going to drive that change and what's important in driving it. The CEC is supporting those teams with our coaches. We've got an extensive group of coaches trained now within the CEC, supporting each of those teams, and we coach monthly, designated days and times with those teams. And we actually have weekly calls to the team leaders as well to ensure that they're on track and to answer any questions. But we're available also to do site visits, and a lot of that's happening now. So those of you in the sites will probably find that coaching team will be visiting you if they haven't done so already. They will be visiting shortly. So we're really looking to link the work that's happened and also working with our falls coordinators in sharing the work, and many of them are actively involved. The CEC has also built a quality improvement database system to monitor progress and to give you data, and as an opportunity as a collaborative to you to share what you're doing. So each of the sites can look at the other sites to see at the work they've done and what change interventions that they've actually attempted to put in place. So we're looking at how we're going to drive continuous improvement. So what are the strategies that people have identified? And it started by doing some baseline work, not only what we did in terms of looking at IMS data, but baseline work looking at what were the problems or issues that weren't being addressed adequately in their wards at that time. So we that identified that they actually weren't looking at orthostatic hypotension. Many also wanted to focus specifically on mobilisation or safe mobilisation and working with staff around that. and some wanted to work on medications, and that's just an example of the different facilities of who's working on those different aspects. Intentional rounding. Now, we've got a few on intentional rounding, and I want to talk about this because I think this is an important part. As an example, many of our teams have said, yes, we've done intentional rounding and we did it for a while and it didn't work anymore. And then we talk to some of our other teams and they say, oh God, it's too busy, we won't be able to do it, there's no way we'll be able to manage getting this done. And we gave some examples. There's been some very excellent work driven in Hunter, New England around intentional rounding, and they have a methodology, but they do it through their Essentials of Care program, and they've got coaches within that program that supports the work and activity that's happening. But when we worked and start working with our teams, we actually had to start unpicking what does it mean by intentional rounding. And generally when we talk about intentional rounding, we're talking about pain, discomfort, devices, clutter around the patient, toileting needs, and mobilising as well. And there are different aspects of intentional rounding, so it's a big thing in itself, but when we start unpicking it, sometimes it's around toileting. And it's interesting when we even start talking about toileting, what does that mean? Now, I have a passion for clinicians to begin to re-embrace the fundamentals, what I call the fundamentals of care. And we know that we've got lots of older people, more and more older people coming in here, and we're learning today they might be with sarcopenia, they may be frail, they've got dementia and confusion, and sometimes that's going to require more time to deliver care. But also it's requiring us to actually provide a structure to how we're going to do that and on what basis will we do that. And with toileting, and particularly for people who are frail, and when we see our data, toileting is an issue. So, but it's just not like we're going to go and offer toileting, have you gone to the toilet? It's, can you move to the side of the bed? Can you stand safely beside of the bed? Can you safely mobilise? Are you able to negotiate with that walking frame? They said, oh, I'm independent, but can they walk with that walking frame to the bathroom, negotiate opening the bathroom door, closing the bathroom door, managing getting on and off the toilet, pressing the button at the back, all those functions that are probably functions and aspects within that journey that might contribute to them having a fall. So it's not, toileting is a really significant issue. We all have to do it. And we have to do it in a way that's safe, particularly with people in our care. So a lot of our teams are now looking at what that means for them. And one of the teams that I'm working with have determined there are certain periods in the day when they looked at their data that toileting was, and people were falling, it was relating to toileting, but it was specific to certain periods. So they've decided at those certain periods, for the people that they know are vulnerable and need assistance, they're going to round. They're going to go and ask them and see if they require assistance with toileting. One of the other things they've found by doing that, the people who are virtually independent, when a question's being asked, they go, oh yeah, that's right, I haven't been, perhaps I should go now. But what's happening is that they're actually, so when we've talked about intention, we haven't talked about intentional every hour on the hour, you have to do this. The team has determined for themselves where their areas and issues are and are beginning to look at what timing is the important time they need to be focusing in on it. Now, one of the balancing measures in all of this as well, and one of the areas that I was also interested in, was how many people do we make incontinent or support incontinence as well when they're in our care? And I've always been a bit alarmed when I have done my little walks around hospitals, seeing the numbers of trolleys with continence pads. And the expenditure, that's the first thing. Having been a num and knowing responsible for budgets, I'm thinking, oh my God, how much am I spending on continence pads? So one of the balancing measures in all of this, and that's not their focus, that was just the way I think, one of their focus was, well, if we improve toileting and we have dry pads, then there's a saving, but also we're actually driving more continence rather than incontinence. So I think it's something to think about, because I think these areas of care, personal care, have often been regarded as not being the important part of what we do in our ability to care and keep people safe. And if we can really identify and skill staff and train staff around how to do this more appropriately, and it might mean that we actually need different staffing levels in our wards and other issues, but this is the process that's going through, and they do little steps of change. The other thing is that's quite common is when we bring a system or change into a hospital, we think it has to be all done all at once. In this process, in this collaborative, we're actually talking just small incremental steps. So we've had some that wanted to dive in and do everybody all at once. We're going, no, just let's do test of change with one patient. Let's try one patient at 11 o'clock in the morning with whatever process we're going to use. Did that work? No, it didn't work. Well, what do we need to change? Once we're comfortable with that, we move to 3, then to 5, and then we begin to expand it up. But what the process of this is that we get reliable intervention happening, but it might take lots of little steps of change to get to reliable intervention happening. What I might say and I can be encouraged by is that the people who are through this process and can see their data on their little run charts, they can actually begin to identify where they're actually becoming more reliable or where there might be some other areas they might want to focus in on. So I've just given that as a broad example. So we've got work happening around screening and intervention as well in some of our sites. And we've got some that are specifically beginning to focus and looking at screening and care for people with delirium, screening for cognition and delirium. The other work that we've done, which is probably newer in some places, is around huddles and safety huddles, what we call. So some of our teams are holding a safety huddle at different times during the day, calling and saying, well, how are we going? Who's at risk? What are the things that we might need to put in place today? And it could be a broad range of things, but particularly in relation to falls, who's at high risk? What are the issues that we might need to address here and now? And you will hear some work this afternoon about different work that's being done as well. We certainly are wanting to support more focus around multidisciplinary sharing and rounding, and certainly how we improve communication at handover, at clinical handover. This is just a screenshot of our quality improvement data system that has the data there for each of the hospitals. That's our hospital admission data, our IMS data. So each facility, each hospital, each ward, each facility can look at their data and they can track their own progress over time, which I think is a real improvement from where we've been in the past, not necessarily knowing to ward level what our data looks like. And this is part of what the collaborative platform would look like. So all our teams and team members are listed, the overall the strategy that they're working on, and each of those teams can go in to look at this particular part. The data's not shared. The hospitalised data or in data between LHDs is not shared, but the actual improvement methodology and the processes and the planning that each of the teams are using certainly is shared, and people can go and look. The idea is share what you're doing and doing well so that others can learn through that. So the Falls Collaborative, this was, we started with 46 teams, but some of you might be aware in some of ours, particularly in Northern Sydney, who's had a large number of teams, there are some hospital closures happening with that new hospital that's opening at French's Forest. And staff were finding it in this next 12 months, with that hospital opening in October, that there's a lot of staff shuffling and all sorts of issues happening. It was a bit difficult for them to manage. So we're now down to 42 teams working on the collaborative, and this is just one example where one of the teams is sharing their journey board. So what it is what they're trying to achieve, how they're going about it, what they've identified as their problem, and what's the story associated with that in terms of our progress to date. There is information around all the resources and that we've developed on the CEC website. It's also on QuidSet website for those of you who are not involved and want to see the broad brush of information that we have there. And we've got quite a good suite of information available. It's on the CEC website under Leading Better Value Care. And I do urge you to go and have a look at that. And Sue did an introductory video. And I don't know how we managed, Sue, to get that short shot of you at that point, talking about the importance of falls and caring for older people in our care. Just to go back as well, I wanted to mention to you that our final workshop will be on the 16th of September, 14th of September. And on the 14th of September, those teams that have been involved will be sharing their progress and best practice. I'm hoping that through, which will be an encouragement as well for those that have done well and really wanting to continue further. I'm hoping that through next year we will begin to highlight those good examples so that we can share that methodology and process and so on in the broader work that we do across hospitals. And we are in a process of talking about sustainability. How can we support this process of change? How can we equip our staff to be more involved in looking at driving clinical improvement using a methodology that does prove to demonstrate when doing well that you can drive improvement in the hospital system. The New South Wales Falls Prevention Network, well, you're all here as a result of being the work that we do within the network, and I thought I might mention and remind those. I noticed on Slido there was another question in regards to the presentations that's been done today. All of that will be up on the network. If you're not a member, I urge you to join. Now, our funding for the New South Wales Falls Prevention Network at this point has been confirmed till the end of the year, and we know there is going to be further, but we haven't had any formal discussion around what that means for us. This network is really significantly important because look at you all and the variation and the group of people here. It's not only clinicians from our hospital setting. We've got growing interest of clinicians and people working in residential aged care, and many of you, when we did our first Slido question, are working in community. And if I might say, some of the discussion that we have is around hospitals are really important, but where the big effort of driving change is what we do in community, and that's going to be really important. How we can feed work into identifying people at risk and moving them into appropriate follow-up with exercise activities, balance and strength, and so on as well. So we do have an evaluation that will be sent out to you electronically, and we will be asking you to please, if you could respond to that, because that will help us forming the discussion around the involvement of this network. And it was interesting, I was able to speak to Nigel today about it, and he's been very much early, as he indicated early on it. And, you know, and we said to him, the effective arm of this working around keeping older people safe and working around active and healthy ageing and all of those messages in the work that we do, the network is the vital communication arm in sharing the evidence and sharing the support. So I do urge you to join. And the other thing I want to mention, I didn't put a slide up, is that the National Australian-New Zealand Falls Prevention Society Conference is in Tasmania this year in November. Dates? I've forgotten. 18th to the 20th. And many of you here already will know about that, and many of you will be interested in, the call for abstracts has gone out, so I do urge you to 22nd of June, and that closes. So we hope that we can share that's happening in New South Wales very proudly at our national conference in Tasmania in November. So thank you. If anyone has any specific questions in relation to the work we're doing, I'm always happy to respond. Thank you.
Thank you very much, Lorraine. That was fantastic. Excellent. Thank you very much, Lorraine. So we've got about 10 minutes for questions due to excellent timekeeping. Well done, Margaret. So it was supposed to be for all the speakers, so maybe to remind people of that, could I ask Vazi and Sue and also Anne to come back up? And then we have some roving microphone people here ready. Do we have a first question? I've got one for Sue. Well, oh, no, there you are. Morag's got one. Come a bit closer so you can get to the microphone.
Okay, it's not really a question, it's just a comment that there's actually quite a lot of people out there with dairy intolerance, and just reminding that whey is related to that. So being one of those myself, I just thought it was worth mentioning that there is quite a big range of protein powders out there. They probably get more expensive, but the options are there.
No, thank you. It's a good point. It's usually the lactose intolerance that's the issue, and hopefully the whey doesn't have too much of that in it, but yeah, absolutely. I think it almost doubles the price. I think I looked and it was about sort of $58 for the same thing you got for 30. But yeah, it's good to remember that. Thank you.
My name's Kate. I've got two questions. One for Sue, following on from the nutrition question, is it possible for these sarcopenic people to get enough protein from diet alone? And what would that look like if it is possible? And also for Kathy, just noticed you said that didn't appear to be evidence for dance being effective in falls prevention, and I was just wondering if you could comment on the possible reasons that might mean, because I thought that was quite surprising.
I'm not a dietitian, but I know you've got to have a piece of steak that fits, it's the size of your palm. What we suggest for people that can't eat a lot of meat is lots of eggs. But because of the issues with cholesterol, a lot of people don't like to eat eggs. It's crazy. And I say, look, you're 82, your cholesterol doesn't matter. The higher the better, actually, which is actually a fact. Your cholesterol can be much higher. So we're using eggs a lot, and you can get a dozen eggs at Aldi for $3.20. So it is really, really very cheap. And there's, and you don't need necessarily the milk. But eggs and fish are clearly good. But I'd really defer to dietitians, and I know there's a couple in the room for that, yeah.
I might talk to you later about the dance. It hasn't been found in any trials as yet. So any other questions for our fabulous speakers here?
Can I ask Sue a quick question? So you threw in that vitamin D levels need to be at 75, not at, traditionally a lot of the literature says 50. Can you comment upon that?
And Vasi would be better at this than I would actually, but that's the the International Osteoporosis Federation's suggested. But Vasi, do you want to comment on that? 50 is what we always used to believe, but they're saying if you can head for 75, that's good. And some people even say 100. I certainly am no expert in that area.
If you're from certain American groups and you're from Switzerland, their guidelines have said above 75, and the rest of the world has said 50. There's argy-bargy about it, but I think everyone agrees above 50. And previously, we would have said 50 and anything above, right? Who cares? And then we start getting things like the CHAMP data, which suggests there could be a problem if it's too high. So, so you have to take that with, so everyone agrees above 50.
Actually, I'll take the opportunity for a follow-on question, Vasi, about the clinical implications of that sort of U-shaped relationship and in community and residential settings.
I don't know what the U-shape means, right? But the U-shape is very interesting when you look at older people. It's the same for BMI, right? People at the highest and BMI, the lowest BMI have higher mortality. And same for cholesterol, right? The same thing. So there's plenty of studies showing that people with really low cholesterol are at high risk of mortality because the fact their cholesterol is so low because they're malnutritioned. And often they're still taking a statin, which is daft, really, which is the point, which I think was the point that Sue was making, right? If, there's something more important than their cholesterol, which is their general nutrition. And the statin in practice could also be causing a bit of muscle weakness. So seems
like everyone needs to be managed by a geriatrician. Is there any other questions? Otherwise, I'll take the opportunity to ask Anne a question. So I think that's fantastic, the investment in these programs. I mean, would you like to comment on whether it's challenging to sort of argue for investment in those sort of programs?
It has been a huge challenge. Just changing the mindset and the cultural change with the residents. It was not easy to get them to participate in these programs, but I guess for us, just a simple change of terminology and giving it a positive focus and a positive spin instead of calling it falls prevention to strength and balance That has played a huge part, as well as investing and making actually changes in the systems and putting it in position descriptions and appointing people for, especially for these roles, are really making a huge difference for us. Thank you. Forgot my presentation here.
And I might ask one, I can't see any hands. Oh, okay, I think there'll be one last question. Good job, Morag. Look at that early prevention of falls.
Sorry, my name's Anna. I'm just wondering, there's no focus at all in these talks about calcium intake, and yet we talk about that a lot in the Stepping On program. What's happening with calcium?
Calcium supplementation has gone through a bit of a downer, really. So following from that, it probably has made dietary calcium more important, because I think the problem was certainly the medical fraternity just didn't ask much about dietary calcium and just went, well, take a calcium tablet. And geriatricians have known for years that people hate taking calcium tablets because they're dirty big tablets and they constipate people, right? So dietary calcium is more important. The question then is it that way? So the more calcium you have, it incrementally is good for your health, or do you need a minimum amount of calcium in your diet, and once you've achieved that, then that's good enough? And there's a bit of debate on that. But I wouldn't see calcium in terms of falls. I would see calcium in terms of your overall nutrition and your overall health. That's probably a better way of looking at it than, again, just focusing on calcium, bones, and nothing else, really. It should be calcium as part of your general diet, would be my feeling. But I'm a geriatrician, so you'd expect me to say that, really, rather than focus on one particular disease.
Excellent. Now, I'm afraid I think we're going to have to finish there because we've run out of time, much as it's a fascinating discussion. So, thank you very much again to all the speakers. And so we're going off to lunch, and so lunch will finish at 1:40. I just have a couple of housekeeping messages on the way to lunch. And so a reminder about the People's Choice Awards for the best poster. And so the posters are in the Cottee Lounge, and the authors will actually be with their posters over lunch. And so, yes, remember to vote, and the voting forms were in the at the registration, and return those to the registration desk.